Good evening. Welcome to Spine Time. Dr. Salama, please go ahead and get started.
Thank you, everyone, and good evening. Welcome to another episode of Spine Time. I want to welcome everyone to this wonderful seminar series where we have discussions on topics related to neck and back pain with leading experts in the field. Today, we will be speaking with Dr. Justin Schwarz on the topic of sacral insufficiency fractures, what causes these injuries, who's at risk, and how are they diagnosed and treated. Dr. Schwarz is an award-winning neurosurgeon at Cornell. He has fellowship training in stroke, arteriovenous malformations, and many other neurovascular conditions, as well as he's an expert in minimally invasive approaches to treating many issues related to the brain and spine. He has expertise in endovascular embolizations, venous stenting, vertebroplasty, and kyphoplasty, and many other cutting-edge technologies that use the tiniest of incisions. So we welcome Dr. Schwarz to this episode of Spine Time. So this webinar series is hosted by the Weill Cornell Medicine for Center for Comprehensive Spine Care, or our Spine Center, which uses many different specialties in order to optimize patient care and provide the most current and excellent care for our patients. Dr. Schwarz, if you can start, can you just give us a little introduction about what the sacrum is and what exactly is a sacral insufficiency fracture?
Yeah, absolutely. So thank you everyone for joining. So sacral insufficiency fractures, they're quite common. So first, the sacrum is really at the base of the spine, and it essentially transmits the weight of the body from the spine to the pelvis. So it can be transmitted to your legs so you can support yourself. The sacrum is sort of this broad base bone at the bottom of the spine that again connects the spine and transmits that force from the spine to the pelvis itself. One of the things that can happen when bones are inherently weak or the calcium content of the bone decreases to a substantial enough level is that area that actually is between where that connection in the sacrum between the spine and the pelvis is, it becomes too weak to really support and transmit that weight effectively. And that can result in very, very small fractures of the bone that does that, or of the sacrum, or as you can see, sort of the wings of the sacrum if you look at the image on the right here. So kind of where those red lines are, that's the most typical location of these kind of fractures. This is first described actually relatively late, so in the 1980s, and it's increasingly found to be a more common cause of very low back pain. Because again, when you stand up and you have any axial or any loading or force on those fractures, like any fracture in any bone, it causes severe pain, and that pain gets worse with walking or moving around. So it's a very underdiagnosed source of pain, of back pain.
Great. So you want to just, again, I think this is a beautiful image of the actual bone that we're talking about, which is sort of triangular shaped and located. So this is a representation of what our spinal column looks like. And this is that bone that you were describing, that triangular shaped one at the very bottom. So the next question is, what symptoms can a patient present with that would even prompt thinking about this type of injury? And when somebody presents with it, what can you do about it?
Yeah, so the symptoms can be very vague and a little bit perplexing. Back pain is obviously a very common symptom that a lot of patients have. So the symptoms are not very specific. So typically the most common thing that we see is sort of a very low back pain, sort of across the bottom, really where the hip bone is across the very low part of the spine. this pain can be quite debilitating. So there's a big spectrum of how much pain patients are in, but typically these are pretty considerably painful, and they affect a patient's ability to stand, to remain standing, or to walk. So really, it has a very high morbidity and really limits patients' activities. A lot of times this can also be experienced as sort of a very vague hip or lower extremity pain. Again, most typically being the worst when patients are moving, particularly standing. So whenever you have more pressure on that fractured bone with standing, again, that the sacrum is sort of what transmits the weight from the spine into the pelvis. So whenever you have something like that sort of movement, that's when we get concerned about a patient having this kind of fracture.
So who might a patient see? What type of physician would diagnose this? And who would be best to work up a patient who presented with all of the symptoms that you sort of just described?
Yeah, so very typically, patients can come from kind of all over. It's not, again, it's, the symptoms are very vague, so it can be a little difficult to diagnose. There are some patients who I see in my office who just have been seen by a pain management physician. They have something else that they have on their imaging that is not related to the sacral insufficiency fracture. And then when I see them, their pain is more classically from that. And then we pursue some different kind of imaging that can really show this better. So really, I certainly get referrals from the pain management physicians who typically see these patients first, who identify them as this as being a possibility. Certainly primary care physicians, if they're well attuned to their patient and their complaints, particularly the fact, if these aren't getting better, they may refer them directly as well. But that's typically where I first meet patients who have this.
Okay. So who's at risk? What types of patients do you see? What are their histories, and what places somebody at risk for having this type of injury?
Yeah, so it has to do with patients who really have weakened bone overall, particularly in the sacrum itself. So I would say certainly the most common population of people that we see this in is in patients with osteoporosis or osteopenia, where the bone has weakened over time. It's typically patients in their 60s, 70s, 80s and above. This certainly has to be on your mind when you're seeing them with low back pain, and then really anything else that can cause weakened bone. So certainly menopause, pelvic radiation, which can affect the strength of the bone, particularly in the sacrum, is a really big culprit too. So, and we consider this sort of population that we have listed here as our quote unquote at-risk population, and the incidence of sacral insufficiency fractures in this population can be as high as 2%, which is quite high.
And oftentimes, at least, so I'm a neuroradiologist, so I see the imaging. I don't necessarily see these patients in clinic or hear their presentation, but I know from the imaging, a lot of we sort of diagnose these a little unexpectedly. People order a lumbar spine MRI, and the history is back pain really, and they're looking for lumbar spine issues, and unexpectedly sometimes we see the sacral insufficiency fracture. But certainly in these populations that you described are the ones that this is more common, at least from the imaging perspective. So it's that plays out in clinical practice as well. So this brings us to the point about how we diagnose this issue. So you can sort of start by describing, if you see this patient in clinic, or a primary care provider sees the patient, what are your first thoughts? What do you think to order, and how to diagnose the patient?
Yeah, so usually by the time I've ended up seeing someone where there's a concern, typically they've had an MRI or at least a CT scan, and really, what tees me off to it is really the symptoms. So if there are symptoms that I can't explain, really low back pain, worse with standing or weight bearing, worse with activity that is is very severe when actually standing, I start to think about this as a possibility. And I really do look at the imaging, whatever imaging they have, quite closely to see if I can see any evidence of there being fractures of the sacrum. Again, when a lot of times when these MRIs are ordered, we're focusing, a lot of physicians are focusing on, is there a herniated disc, or is there any narrowing in the spine? And they're not necessarily looking in at the sacrum itself, which may not always be easily seen on that kind of imaging studies that we get. So a lot of times you can get an idea if it is on the pre-existing imaging, but certainly what I use most is really what a patient tells me. So the kind of pain that they have, and certainly pain that hasn't been getting better. And if they don't have any imaging that I think is appropriate, then I usually order specific imaging so that we can really tell and see if there's a fracture there that we really need to identify.
Yeah, so from the radiology perspective, patients often will first present anytime they have back pain. Somebody might order them an X-ray or a radiograph, which is super easy and inexpensive to get. But unfortunately, just X-rays are not very good at picking up this abnormality. It's going to be missed a lot of the time, particularly if it's, what we describe as a non-displaced fracture or just a hairline fracture that goes through the sacrum. You're probably not going to see that on X-ray, no matter how good your image is and no matter how good your radiologist is. So, the workhorses for diagnosing these types of injury is really CAT scan and MRI. But even on CAT scan, which is the bottom image here with that red arrow, the red arrow is pointing to that little sort of grayish line that's going through the bone there. The bone is white, and that little diagonal gray line is the sacral insufficiency fracture. But you can see that it's a pretty subtle finding on CT. So if you're really looking for it, certainly you may be able to pick it up on a CAT scan. But if somebody has a CAT scan and they still have persistent pain and you feel like their pain is out of proportion to the findings and you can't account for it, definitely an MRI is really the way to go. And it's going to be the thing that sort of confirms your suspicion if you're not certain based on the CAT scan, because on the MRI, we can see a lot of swelling and fluid in the sacrum when this happens. And it has a particular appearance on imaging. We call it an H-shaped appearance. So if you look at the top left image that says MRI, the white part is the fluid or edema or swelling in the bone. And it has a little bit of like this butterfly shape or H shape. And that's the typical feature that we're looking for on the MRI to identify a sacral insufficiency fracture. And sometimes I sort of touched upon this, but an ordering provider may order a lumbar spine because the patient's complaining of back pain. And they're looking for the things that you talked about. They're looking for vertebral body, deformities and other types of fractures or disc disease. And we don't get an entire picture of the sacrum. So sometimes we actually have to then order or have them order another study and specifically looking at the sacrum. So an MR sacrum, specifically looking at that, can even be better at picking up this abnormality than, let's say, a lumbar spine, which may or may not include the abnormality in the image. So I think that's important to understand. And then there's something called a bone scan, which can pick up inflammation in the bone. And you can see again, the bone scan, that all that dark signal there is the abnormality. And again, it makes that H shape, which is the typical shape that we see of the abnormality on imaging. So basically the take home message is really, if an X-ray is not going to diagnose this, and you need some other modality to identify your sacral insufficiency fractures, if that's something that is being considered based on the history. So we talked about how these patients present and which patients are at risk. We talked about what we do when we're suspecting that this might be going on in the patient. Once it's diagnosed, what do you do about it?
Yeah, so my approach really depends on the amount of pain that a patient's in. So certainly, some people may have some pain that's in their lower spine region. We see that they have sacral insufficiency fractures, but they're still able to do everything that they usually do. They just have a little bit more discomfort, and that pain is addressed by just over-the-counter pain medication or a short course of a bit stronger medication. In that situation, we don't rush in to do anything more invasive than that. Typically, we want to confirm that if there's weak bone overall or not, because if somebody does have osteoporosis, which we typically confirm by getting other confirmatory studies, then we typically refer to either their primary care provider who's comfortable with treating their osteoporosis, and there's a myriad number of medications that are available now, or to an endocrinologist to also do the same thing. So the overall goal there is to just, over time, one, prevent the bone from getting weaker, and then two, to over time allow that bone to build up strength. And in that situation where patients don't have severe pain that's limiting their ability to live their life, those fractures typically heal on their own. And really, we don't want somebody to just not be walking around or living their life. We want people to remain active, because when you start to be in bed all day because the pain is so severe, that's where we start to encounter other issues and other medical problems like blood clots in the legs or the lungs, just general atrophy, which can, lead people down a very vicious cycle. So we really try to avoid that. So that's for the more mild symptoms that we have. Certainly, so just over-the-counter medications at first to see if that helps, and certainly physical therapy. So, I think physical therapy is one of the best things that we can ever do, because it helps maximize our function and increase the strength and the flexibility and help minimize pain otherwise that's from a muscle as opposed to the bone. If that doesn't work, then we consider more invasive procedures. And one of the procedures that we do is called a sacroplasty, and that can really help reduce that pain level from the sacral insufficiency fracture quite significantly. No procedure is going to knock out all of your pain. So I typically tell my patients that, the goal is not to get you from 100% to zero pain, or from a 10 in terms of your pain level to 0. That's can happen from time to time, but really it's to get the pain level to a point where you can still function, still live your life, where maybe it's not an 8 or a 9, but it's down to a 2 or 3. And now with taking some over-the-counter Tylenol or ibuprofen, your pain is well controlled where you can, live your life. The technique that we use, so a sacroplasty procedure, has the advantage that it's a very minimally invasive procedure. So typically it involves essentially just a long needle. The incisions for the needle are about 2 or 3 millimeters, so significantly less than ½ an inch. And we do this under direct visualization with X-ray. So we're able to see exactly where we want to put the needle, which is essentially directly where those fractures are, in the most at-risk part of the sacrum, and the part that specifically transmits the most force from the spine or the base of the spine to the pelvis itself. We're able to do this procedure usually under just local anesthesia and sedation. So, sort of like a twilight anesthesia, if anyone's had a colonoscopy before, where you're awake and we're able to communicate with you, and you don't need to be completely asleep, but you don't remember the procedure. So it's a very, very comfortable level of sedation. In some situations, we may have to put patients completely to sleep, but that is not the norm for us. It's an outpatient procedure. The procedure itself is about an hour or so in the procedure room. And usually patients go home about 2 hours after the procedure. So usually it's about a half day. And it doesn't require any substantial holding of blood thinning medication. So either antiplatelet or anticoagulation. So we typically we can do these procedures on aspirin. So if anyone has, obviously the biggest population for this is the older population, where the incidence of people also having some cardiac disease or cardiac stents or peripheral vascular stents or AFib that needs to be anticoagulated. We can typically do this with patients on aspirin, which really minimizes the risks otherwise outside of the procedure. And then if for any anticoagulation, we usually only require it being held for usually 2 to 3 days, which for most patients we can get away with and really not put people at significant risk. So it's a minimally invasive procedure. And the potential benefit is huge because, really patients respond very well to this. And if they have 8 or 9 out of 10 pain, very severe pain, we can typically knock that down by at least 50%.
in terms of refracturing after a sacroplasty, does it change your risk for another insufficiency fracture or anything of that nature?
Yeah, so good question. So typically, we try to get the best fill. So really what this procedure does is it essentially puts a special medical cement. Really, it's the same type of material that dentists use to fill cavities. And we really try to fill the most at-risk area of the bone the best that we can. So it's pretty uncommon to see fracture in the same area of the sacrum after we've already treated. Certainly, if we feel like we haven't gotten adequate fill, if there is a new fracture, we can certainly go back and retreat that area. But typically our algorithm is that if somebody has a fracture of any bone due to osteoporosis or osteopenia, we treat to help reduce the pain by doing the sacroplasty, putting them on over-the-counter medications. And then the next step is to get them right to treatment to make the bones stronger. So that's really the biggest thing, is to treat the underlying cause of what puts somebody at risk for having that sacral fracture, which is the weak bone itself. So typically, if we're able to do that, it's quite effective at preventing patients from having repeat fractures either in the same area or elsewhere.
And how soon after the sacroplasty do patients get pain relief?
Typically, it's right away. So the cement, really it hardens within essentially a few minutes before, right after we're done with the procedure, usually about 5 or 10 minutes after that, whatever we put in there is set and it's not going anywhere. And that typically provides, immediate relief. What I typically say is that if it's pain from the bone, we help that pain from the fracture bone pretty much immediately, but there's a bunch of other drivers of pain as well. So there are muscles that attach on the sacrum. There are muscles in that same area. And then when somebody has a sacral fracture, they alter their gait, they alter their activities. So there are other drivers of the pain. Those things don't get better right away, but they will get better after, typically with physical therapy and just over-the-counter medications. And that's typically why I say that with this procedure, we reduce the pain by about 50% on average. Some patients may get a better response than that, but usually the rest of that pain that they're experiencing is coming from muscle atrophy and fatigue and irritation, which typically gets better with physical therapy and over-the-counter medications.
That's great. And well, you described that, it's a same-day procedure, which is amazing to get this type of treatment and pain relief, and you don't have to stay overnight in the hospital. What would a patient expect their next week to look like in terms of what are they allowed to do? What restrictions might they have? And when do you follow up with the patient after the procedure?
Yeah, so we usually, right after the procedure in the recovery room, after about an hour or so, we have patients get up and walk and see how they're feeling. Again, the vast majority of patients have about a 50% reduction in their pain immediately. And then what we say is, we want you to live your life. So sort of common sense things were walking upstairs, getting up out of bed to go to the bathroom yourself, and those things. Those are things that we want you to do. If you feel good and really good, we want you to walk as much as possible. That's great. It keeps you active. But we really want you to hold off on doing anything more than that for usually at least a couple of weeks. So if you lift weights, if you do anything more strenuous, if you enjoy running and those things, we typically want you to not do that, at least for the first couple of weeks. After 2 weeks is typically when we see patients in the office to just check in on their progress and see how they're doing. Obviously, if there's an issue between the time we do the procedure and the scheduled appointment, we adjust that as we need and see patients sooner. But typically by about 2 weeks, people are feeling pretty considerably better than what they were before the procedure. And then at that point is when we would like them to start doing physical therapy, going to outpatient physical therapy and starting to really gradually increase their activities. Before we do the procedure, we certainly talk about treating the underlying cause, which the underlying cause is weak bone. So we want them to, our patients to really either talk to their primary care doctor, or we refer them to one of the endocrinologists, within our system, who we work with quite consistently, to have a plan to treat the osteopenia or osteoporosis, again, to help prevent this or additional fractures in other areas in the future.
A little bit going backwards, if somebody chooses to, or they're not in severe pain, or they're not a candidate for, they choose not to have a sacroplasty, and they want a conservative management sort of with oral pain medications and addressing their underlying maybe metabolic or bone density issues, how long do these fractures take to heal? And are there, obviously we want them in physical therapy to keep their movement and things, but are there restrictions on their activities if we don't treat with sacroplasty?
Yeah, so pretty similar again to right after the procedure if we don't treat. So we recommend, the things that you need to do that you can do within a reasonable amount of pain. So we still encourage walking. We still encourage, if you need to go upstairs in your home or those kinds of things, just regular activities of daily living. We don't want you to stop doing those things. And I think that if you're unable to do those things with oral pain medication, it means that we have to sort of escalate the, what kind of care we're giving you. If the pain is mild to moderate, if it's, if it's dealt with by taking over-the-counter pain medications, we would still recommend going in to see and to having medical therapy to help strengthen the bones, because that also helps heal the fractures. Like any broken bone, it does take some time. The sacrum is a little bit more difficult because there is a little bit more stress on that area that's fractured. So it may take a bit more. So it could take, as long as a few months to have progress. Some patients, usually after they have this fracture, that pain is really severe for the first week or two, and then it should gradually start to improve. If it doesn't improve, that's also a sign that we probably have to escalate the kind of care that we're providing, meaning that just conservative therapy is probably not going to work.
Great. And we have a question from somebody watching on YouTube. So would this type of fracture or other compression fracture look like a bone cyst? So typically they look pretty different on imaging. Bone cysts have a different shape and contour. The sacral insufficiency fractures that we sort of went over are very linear and they're hair-like almost, and they have this H shape. So I think it would be unusual to mistake a sacral insufficiency fracture for a bone cyst. What are your thoughts, Dr. Schwarz?
Yeah, no, I completely agree with you. Yeah, I think they look very different.
Great. Any other thoughts on sacral insufficiency fractures and sacroplasty?
No, I think I think it's a very effective procedure. The risks associated with it are quite minimal. The potential benefit is huge for patients. It can be life-changing if patients are really in bad pain. And it's definitely a multidisciplinary approach. So, certainly the most important thing that I would say is that, really having care from your primary care doctor or an endocrinologist to treat the underlying cause is incredibly important. Because we see that if patients don't get treated, they can have additional fractures, either other locations or similar location in the future if they don't.
Great. So I want to thank you for taking the time to be with us and talk about this important problem that some of our patients experience, and your expertise in the field is wonderful. And thank you all for those that joined us. And if you have any questions, we're always available at the Spine Center to offer our help. Thank you, everyone.
Thank you so much.